Shall we?
We
Oh,
shall.
okay. Welcome to our first webinar of the year. My name is Ting Dai, and I'm a Bernard Ferrari Professor of Business at Johns Hopkins University and the co-chair of the HBHI Workgroup on AI and Healthcare. It's truly a pleasure to have all of you join us today. For those who don't know what the HBHI stands for, we are the Hopkins Business Health Initiative. We are a university-wide effort dedicated to address critical challenges at the intersection of health and business. Within HBHI, the AI and healthcare workgroup focuses on exploring how AI can transform healthcare from improving medical decision-making to addressing systemic barriers in adoption. Our mission is to create a collaborative platform for dialogue and innovation across disciplines. It is now my privilege to introduce my co-chair of the workgroup, Dr. Lisa Wolf. Dr. Wolf is an associate professor of pediatric endocrinology at the Johns Hopkins School of Medicine and the director of the pediatric diabetes program. Her work in advancing healthcare delivery for pediatric populations has been inspiring and served as testament to the transformative power of cross-disciplinary collaboration. Together, Risa and I are thrilled to host today's fireside chat on AI for medical diagnosis and prognosis, reflections and vision for 2025 with Dr. Ziad Obermeyer, moderated by Dr. Polsky. We are confident you will find the discussion thought-provoking and engaging. With that, I'll hand it over to Risa to introduce Dr. Polsky and Dr. Obermeyer, and thank you again for being here.
Welcome, everybody. It's great to have everyone back after the new year. It is really my pleasure to introduce our speakers today. So I'm going to start with our very own Dr. Dan Polsky, who is a national leader in health economics and policy and the director of the HBHI Hopkins Business of Health Initiative, a university-wide effort to tackle the most pressing challenges in healthcare delivery and financing. Dr. Polsky is the 40th Bloomberg Distinguished Professor of Health Economics at Johns Hopkins University, holding joint appointments at the Bloomberg School of Public Health and the Carey Business School. Before joining Johns Hopkins, Dr. Polsky spent 2 decades at the University of Pennsylvania, where he held leadership roles, including serving as the executive director of the Leonard Davis Institute for Health Economics. He is a member of the National Academy of Medicine and has advised key organizations like the Congressional Budget Office and the President's Council of Economic Advisors. As director of HBHI, Dr. Polsky is leading a transformative effort to integrate health economics and business strategies into healthcare innovation, advancing both research and real-world solutions. Please join me in welcoming Dr. Polsky. And now I'm going to introduce our guest speaker, Dr. Ziad Obermeyer. It's really a pleasure to have you here with us today. He is the Blue Cross of California Distinguished Associate Professor at the Berkeley School of Public Health. Dr. Obermeyer is a trailblazer at the intersection of machine learning and health, exploring how AI can improve medical decision-making and uncover hidden patterns, like identifying new causes of pain or linking body temperature to health outcomes. At the same time, his groundbreaking work has revealed critical pitfalls, including how algorithms can scale racial bias. His research has shaped practices across healthcare, informed policy, and even led to testimony before the Senate Finance Committee. Dr. Obermeyer is also the co-founder of Nightingale Open Science, a nonprofit advancing medical AI through open access datasets, and Dandelion, a startup driving innovation in health AI. He's named one of Time Magazine's 100 most influential people in AI, and he's also an emerging leader of the National Academy of Medicine and a practicing emergency physician. So please join me in welcoming Dr. Ziad Obermeyer, and we really look forward to the discussion that we'll have today. And I'll turn it back over.
To me, right? Yeah, so thank you so much for those introductions. Ziad, why don't we just jump right into it? Let's just start at the top. I go to the doctor, I read about my condition, I put into ChatGPT, like, all right, this is what I have. I learned so much from AI. People, not me, but people might take a self-driving car to their doctor's appointment and they show up in the doctor and it looks like it did when they went to the pediatrician 20 years ago. like all this hype and like no, it seems like no action yet in healthcare. You know, what gives? What's the story here?
Give me 1 second. I'll just type that into Chat GPT and get you your answer. Yeah, I think it's a fundamental question that I think lots of people wonder about. Because on the one hand, yeah, there's so much hype, and on the other hand, we're still faxing stuff to our doctor and getting expensive care that sometimes suffers in quality. And so I think that one of the things that I've learned over the past few years of working in this area is that we have a bunch of intuitions about what AI is good at and what it should be doing. And those intuitions are, I think, in many ways based on what humans are good at and what they can do. And so we see like, oh, this thing can like beat grandmasters at chess. Surely it can figure out this other, but AI is a lot more like a sort of weird alien intelligence than it is like humans. And so the things that it's good at and the things that it's not good at are actually not that intuitive. And so I think that at least has led me to think a lot harder about like what are the kinds of problems where AI can really add value in the healthcare system, and what are the problems where it's going to stumble. And I think anyway, so that's my view. I think there's another view, which being in the Bay Area, I think I'm in the minority here in this view, because I think a lot of people think like, well, why are you making this so complicated? Doctors are like black boxes. They see stuff about a patient. They output like a note that details like diagnoses and treatment. Why can't we just run the Chat GPT playbook and just like, input the patient stuff and output the diagnosis and treatment plan? And I think that brings us to a very important issue, which is data. So, to train these language models, tech companies trawled the entire internet, published books, patent application, so there's like a lot of data on language and text. And that's the foundation of these language models that are doing amazing things. And if you think about the equivalent of that for medicine, it's not that we don't have data. We've got lots of data. We've got a lot of insurance claims. We've got the text that doctors write about patients. We see the prescriptions that they write and the surgeries that they do. But much like language models, the problem with that data is that that data is a reflection of the world as it is, not the world as it should be. And so when AI learns from those kinds of data, it's learning about the healthcare system the way it is today. And I don't think I'm in the minority when I observe that the healthcare system today is not perfect. It is not a well-oiled machine that consistently outputs high quality at low cost. And so if we simple-mindedly train AI on data from today's health system, we're going to get today's healthcare, but automated in a way that no human can do anything about it. And that's actually very different from driving a car. Because I think when we have an AI system that's learning how to drive a car, we know what good driving is and we know what bad driving is. We know that if the car hits a pedestrian, that's bad. When a doctor writes a prescription, is that a good prescription? Is that a bad prescription? When they do surgery, like for back pain, is that good? Is that bad? So I think that's the fundamental problem that is like a huge roadblock in medicine, much more than it is in like self-driving cars or lots of other places. It's the data. And it's two things about it. It's data access, because not a lot of people have access to the data that we do have. But beyond the data access, it's like knowing what to do with those data and knowing how to learn what's right and what's wrong from those data. It's actually a really hard problem that all of us are just trying to figure out now. So I think that's the major problem. And I think that's the access, and then the knowing what to do once you get access are huge and underrated problems that are blocking a lot of AI today.
So that is a tremendous perspective there, and it makes me think we should have changed the title of this from the role for diagnosis and prognosis. But I imagine there really is a lot of important use cases. So maybe we can start there. Where can AI be useful for improving diagnostic accuracy and prognosis in healthcare, which is really a big role for what a doctor does. It's kind of the I guess, the doctor replacement part of AI in healthcare.
Yeah, no, I think it's a perfect title because I think if I were trying to summarize like where is AI going to add value, like what are the problems that AI can solve in medicine? It's those two, it's a diagnosis and prognosis. I think, when we think about medicine and what doctors do, I think we tend to think about like treatment. We tend to think about like, oh, the new drugs that doctors are giving, or like there's some new surgery and there's a robot. Like, so I think we're very keyed into treatment, and a bunch of the statistical and methodological infrastructure that we've developed in medicine, randomized trials and inference, like all of that is about treatment. But I think and so there's like a ton of technology and statistics and like infrastructure behind that, like finding the next big treatment for a disease. It's weird that we don't have that for the disease itself, like for the diagnosis of action. Like, I don't even think I have a great answer to the question, what is a diagnosis? And so on the one hand, we have this super technologically advanced machine for finding treatments. But one of the key inputs to that thing, it's like treatment for what? Is in this weird like arts and crafts world where, like, just to illustrate, like, what is depression? Depression is having 5 out of 9 of the items on this checklist that we've developed over the past like 40 or 50 years. Is that really depression? That doesn't seem like depression to me. Like, I think I can think of a lot of other definitions of depression that don't involve a checklist. And so I think that that's the place that AI is going to really transform in medicine. It's figuring out, okay, sure, I've got lots of treatments and lots of decisions that I need to make, but all those decisions are contingent on understanding like what is going on with this patient, given the X-rays and the MRIs and the laboratory stuff. Like, so compressing all of this complex data down into one statement about like, oh, this person in front of me is in the midst of having a heart attack. That's super valuable. And that's a great AI use case. And it's the kind of use case that we actually have data to help us train algorithms to do.
Oh, that's so useful. Maybe just follow up. So the depression example and what is a diagnosis? I guess what comes up for me is it's useful to have a bucket to call something if there's something you can do about it. So if you train the model based on the set of characteristics where, say, this drug might actually work, then you could, call it whatever you want, but the set of circumstances by which this thing will make you not have these problems.
Yeah, let me give you just a really crisp example. And I love your focus, Dan, on this is your kind of speaking as an economist, like you're very focused on the decision, like just the concrete thing that we like, and that's exactly right, or at least that's how I think about things too. So in my clinical life in the emergency room, one of the things that all of us obsess about is diagnosing heart attack. So heart attack is a hard diagnosis to make. People can have very subtle symptoms. They can still be having a major heart attack. And so it could, like, basically 90% of the people in the ER based on their symptoms could be having a heart attack. But you can't send 90% of patients in the ER to get a catheterization because that's expensive and it's risky and it's like, so you have to choose very carefully who's going to get the definitive test for heart attack. And so this is a great machine learning problem because if I had some machine that could tell me, okay, this person in front of me has a 30% chance of that they're having a heart attack, and that's why they're having the symptoms and the laboratory studies and the electrocardiogram they're having now. That's super useful information because I can send that person to the catheterization laboratory and confirm the diagnosis and treat the problem. And then a bunch of other people that I might have erroneously tested, I don't need to send because they have a probability of approximately 0. So working backwards from the concrete decisions that based on the technology that we already have and optimizing the use of that technology, those are great AI use cases. And I think that's very much in this box of diagnosis.
So I would be remiss not to talk about your 2019 paper in Science that really set off just a really important conversation, but also a number of efforts to mitigate bias that might come from AI, and in particular, racial bias. And so, I mean, I would love to reflect on that paper, but really, can you bring us up to date a little bit. Like what type of progress has been made in addressing bias? Because, as you mentioned, if we're just training on data that exists, if decisions are biased, that'll be baked in. So it'd be nice to know that we're making some progress on that front. Can you give us an update?
Yeah, I mean, I think you summarized the basic idea very well, which is that a lot of algorithms, including those used at a very large scale to help hospital administrators and insurance administrators make decisions about who gets access to care, those algorithms learn not about who should get access to care, but who has gotten access to care in the past. And the algorithms see, oh, these affluent white people get a lot of help with their knee replacements and physical therapy for their knee and outpatient psychiatry. And so it sees that, and it, because we've told it, just predict what's going to happen based on the data you have. It says, yeah, that must be the right thing. And it doesn't see that there are a lot of less fortunate patients who also need help with their knee pain and their mood and all these other things. But because that's not in the data, because our system has all of these structural biases built into it, the algorithm doesn't see those needs because they're currently not served today. And I think that basic insight cuts across lots of the cases of algorithms behaving badly that we've seen. In the news recently, there's like claims denial or people being kicked out of rehab facilities because their length of stay is, too long, according to the algorithm. All of these things have the same problem, which is that they learn about the world as it is, but the world as it is not always a great model for the world as it should be. And so I think, we showed this in a family of algorithms that were used for, about 100 million people every year in the US to allocate population health management resources. In follow-up work, we found similar problems in a bunch of other algorithms used for scheduling office visits, for optimizing other kinds of care, for figuring out who needs to be in the hospital, who's at high risk of readmission, who's not, things like that. So these kinds of biases are everywhere. And I think that the nice, at least like the glass half full part of the story is that I was really impressed by both the people who are making these algorithms that turned out to be biased and the regulators that I worked with, that everyone wants to fix this problem. So this isn't a case where, yes, these corporations are making biased products, but it goes to their bottom line, so they don't care. It was not that at all. Everyone that I talked to at these companies was horrified that their products were flawed in this way and really wanted to fix them. And so I think that positive energy was really nice. And I think in this case, it helps that the incentives are actually aligned. Like, I think that if you want to save money in the healthcare system, you actually get people primary care and access to preventive care that they don't currently have. And those patients are disproportionately underserved by the current system. And so that's, I think, an important point here. But there are lots of efforts now to kind of create alternative algorithms. And so, the California state Medicaid program, for example, used to be using one of these cost predictor algorithms that we found to be flawed. And they commissioned a new algorithm to be built that actually was much closer to the corrected version that we ended up working with the original manufacturer of the algorithm to create. So I think there are lots of examples all over the country in both the government and in private sector of people taking these results seriously and using it to build the next generation of algorithms that sees health needs rather than just health costs or the health care that people are getting.
Well, I appreciate the half full part being around aligned incentives. But as an economist, there's on the one hand and on the other hand. So maybe we could shift a little bit to misaligned incentives. And I guess the topic, and I think we've talked about this before, is there's a lot of great algorithms, a lot of amazing ideas that are being developed, like and it's an explosion of ideas that could be implemented potentially in AI and healthcare. But we have insurance. We have a very complicated system, as we kind of kicked off with, and physicians get paid to do stuff that where AI might potentially not be a version of the same thing where we haven't really figured out how to pay for it yet. Anyway, I'm just listing a couple of the potential barriers, but maybe you could speak to what are barriers or facilitators to getting really useful AI in, say, diagnosis or prognosis, or even more broadly, implemented in the healthcare landscape. Maybe you could speak a little bit to that.
Yeah, it's such a critical issue, and I think that it gets correctly a lot of the blame for the reason that AI is being held back. Is that, oh, I've come up with this great thing that's actually going to allocate some preventive care intervention, and I just can't get anyone interested in it at the hospital because it's going to reduce the amount of treatments that they end up giving, and it's gonna impact their bottom line. And I think that, or there's a version of that with insurance companies or whatever. Let me just give you an example to make it concrete. So I have a project right now that we get a bunch of electrocardiograms from a region in Sweden. We link them to death certificates, and that lets us predict a thing called sudden cardiac death, which is exactly what it sounds like. It's someone with basically no risk factors that doctors know about that just drops dead. I think most people, sadly, will know somebody that this happened to. I know a few, including a mutual friend of ours, Kevin Volpe, who's been very public about this happening to him. Kevin, luckily, was sitting next to someone who knew CPR, and so survived. But hundreds of thousands of people every year don't. And if you think about this annually recurring catastrophe, it's clearly a huge problem for patients, but it's actually not a huge problem for insurance companies. Because for insurance companies, a basically healthy person who's paying their premiums and who suddenly dies out of the hospital without needing an ICU stay or a bunch of expensive things at the end of life, that's actually the opposite of a problem for an insurance company. I'm not saying that insurance companies don't care, but this isn't going to make the top of the insurance company's priority list because this isn't costing them a lot of money. So that, I think, could be interpreted as a blocker and a glass half empty thing. But I think the thing about the US health system, for better or for worse, is that it's extremely heterogeneous. And even though we tend to think about the main customer as either health systems or insurance companies, there's a lot of potential customers. So for example, Medtronic or Boston Scientific make the devices, the implanted devices that prevent sudden cardiac death. Maybe they're a customer. So, maybe actually you sell this direct to patients who have ECGs lying around and just want to know what their risk is so that they can go see their doctor. So I think that there's an expansion of possibilities that I think will increasingly become apparent as better and better algorithms come online. That I don't think this is going to translate 100% of the inefficiencies in our health system into like solutions, but I think there's a lot of people at the table when it comes to these like complex problems, and some of those people have aligned incentives, and finding those people and building the relationship with them, even if they're not traditionally like who you think of as a customer of AI or information. I think that's at least the strategy that I'm pursuing.
And maybe just to follow up on that, especially wearing the hat of the Hopkins Business of Health Initiative, where we really try to bring together experts from many different fields across medicine and public health and business to really collaborate on problems, thinking about problems, understanding problems, and developing solutions in a collaborative approach. It kind of starts from the beginning. It sounds a little, quite a bit actually, that's you're building relationships, finding the customers, and maybe for many people that are tuning in, that are tinkering with algorithms, just maybe speak a little bit to the value of connecting and when to connect in the development process.
I think what you're doing sounds super valuable, because I think the reality right now is that this market is, it's not a market. we're so early in this world of medical AI that, a bunch of foundational things that need to happen for markets to work just haven't happened yet. So like, a very fundamental thing that you need in markets is prices. And we don't have those yet. Like nobody knows what people are willing to pay. Nobody knows who's willing to pay it or like so I think that just really highlights the value of what you're doing at this initiative, Dan, which is bringing people together so that at least people can start talking. And I think that, a really important part of what it sounds like you're doing is bringing together a diverse group of people, diverse in every way, diverse personal backgrounds and things like that, obviously, but also people from different parts of this healthcare ecosystem, from devices, health systems, different kinds of health systems, for-profit, nonprofit, government. So, I think that like having a lot of people just mixing together and talking about that's how innovation has happened in every other part of the world. And I think it's that community of people, happen to be sitting next to each other at an event or a dinner who start talking about a shared problem is one really, really important component. And then pairing that with the other important component, which is like then those people need to have access to the data to build the thing that they're talking about without having to ask a million people for permission or go through like a 3-year long protracted negotiation with the health system or an insurer to get access to the data. That's the other problem because, translating those conversations into a real thing, there's an initial valley of death where good ideas get lost because you can't easily test them to see if it's a good idea or not. And what does that look like? That looks like getting access to a data set and seeing if you can actually build the algorithm that you've been talking about. And because it's so hard to do that, and because these ideas are risky, by construction, like all good new ideas are risky. Otherwise, someone would have done them already. So you need some way to de-risk those ideas at low cost without having to pay this huge fixed cost of like a new data use agreement. And that's something that I've been working on a lot, as you know.
Yeah, it's very, 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 very important to think about. And I imagine people that there are people in our Zoom room here that have already experienced some of those frustrations. So I'm glad you're bringing voice to them and coming up with solutions. And so just I have like just 2 more questions. So I want to reach out to our participants, our 150 or so participants, to throw some questions into the Q&A. We'll be getting to them in just a few minutes, and maybe turn my last couple of questions to projecting into the future. Here we are at the beginning of 2025. And I know you're are no worse at predicting the future than anyone else, and we would value your thoughts on what we can look forward to in this area of diagnosis and prognosis. Maybe something you're working on that you have a lot of high hopes for in terms of innovation and advancements in AI and healthcare.
Yeah, maybe what I'll answer with a kind of boring point, which is that a boring point about an exciting set of new technologies. So I think that right now, the bottleneck in AI, which is much like the bottleneck in drugs, it's not a shortage of great ideas. It's a shortage of like the next steps. And so, one next step we've already talked about, which is like access to data, validating those data, validating an algorithm in a diverse data set to make sure it's actually working well and it's working well for everybody, not just people in Palo Alto or Rochester, Minnesota, or wherever the algorithm was trained. And then the last part of that chain of like translating an idea into impact is actually an evaluation. And I think that, a lot of people who develop algorithms are understandably very frustrated because it's hard to convince doctors, health systems, whoever to use the thing that they've made it through these first few things and they've got something that, it works on a diverse data set. And I think the thing that's missing is actually a fundamental part of the health technology playbook and has been for a long time, which is that how do we get new technologies into use in the healthcare system? Well, we run a randomized trial. and we just see if the thing works to do the thing. Like, does it accomplish the goals? And not just the goal of predicting something accurately, but does it actually make a difference for patients? So I think that having that's the thing that I think is going to be most transformative is when we start seeing randomized trials of artificial intelligence algorithms that actually translate into measurable improvements in patient outcomes. And I think that that's the cornerstone of adoption. It's the cornerstone of getting someone to pay for it, because now you can say, look, there's a 30% reduction in hospital admissions when I use this thing. Now you know how much to pay for it, because then you can just use the same playbook that the pharmaceutical companies use to price a drug to price your algorithm. And it's very straightforward. But you can't do that without a trial. And so I think that applied playbook of like creative idea, show it works in data, show it works in the real world with the playbook that we use for showing things that work in the world. That's the thing I'm really excited about. And I think we'll start seeing those in the next 5 to 7 years.
And how, when I think about that, the first thing that comes to mind is as opposed to like a trial using a pill, which has like a chemical composition that you can, look over time that it will be maintained, it'll be in a patent. But these algorithms, the best algorithms, I guess, would be adaptive. And as, new information will come and it'll be constantly changing. Like, I got an update on my computer every couple of months. But that trial might have been in that first iteration. And how does that come in to our current way of thinking about trials, but also like the role of a regulator and, developing the trust to say this is something that's gone through our approval and it's safe and effective, and then it's approved and it works for drugs because the drug doesn't change. But what happens? How does that, how do we adapt to that new?
How do we adapt to adaptation? It's a super important question. And I'll say that it's not totally different from some of the issues that you face when thinking about a drug, because even though the drug itself is a constant chemical formulation, it's applied in populations that look very different from the populations in which it was initially validated. And so I think so I think that's provoked a lot of efforts on the drug side to do real world evidence and continuous evaluation and quote unquote phase 4 trials or these kinds of things. So I think we can learn a lot from that playbook. But I don't think the fact that algorithms, adapt over time undermines the fundamental need to show that at least the first version works. Because usually the algorithm has an algorithm. In other words, I'm training it to predict this thing in this kind of data. I'm going to show that works now. And you can even build the adaptation into the trial. So for example, I have this effort underway to implement a heart attack detection algorithm in the ER with a hospital system called Providence, which is a huge system up and down the West Coast. And what we're doing is that in that trial, we're building into the trial that the algorithm is going to refresh every few months. And that's just going to be part of the trial. And so we'll be able to look to make sure that the performance is not changing over time. And that'll at least, does it tell us that's going to happen in the future? No, but at least lets us say, okay, in the data that we have, we're going to show you that, version 0 is the same as version 1 as version 2 in terms of its ability to predict this thing. And here's the treatment effect over time. And so I think there are ways to kind of build that into the design of the trials as well. So I don't think this is a deal breaker for doing trials. I think it does raise a bunch of questions about how you set up the monitoring systems, just as it has on the drug side.
Yeah, and so you said that at the end, like the monitoring systems might be, that also there'd be a feedback loop of maintaining the trust that even as it adapts, it continues to work and people.
Yeah, and I think it's actually a lot easier with algorithms than it is for drugs, because in algorithms, they're up and running in the health system. So you can have daily readouts of the predictive accuracy of the thing to make sure that at least that's not changing. Now, you can't have daily readouts of the treatment effect because that's a different statistical problem that's more demanding. But at least the primitive that the algorithm is outputting, the prediction, that you can check very carefully and very frequently.
So I keep thinking about trust. So, but I want to turn to, the role of the physician. which is, I would say is a more trusted actor in the healthcare delivery system than the AI algorithm. But AI is often thought of, in this idea of prognosis and diagnosis is potentially doing things that doctors do. Is there a role for AI to potentially replace a lot of what doctors do? Should doctors feel threatened? And I think some conversations we had before is the AI that is a complement to what a physician does, a provider does, a clinician does, or one that is a bit of a substitute. I think the economics of it is boy, if AI can do something that would pay a doctor a lot, then I'm all for it. But it seems both on a customer perspective, but also on how we interact with the healthcare delivery system, how we trust the healthcare delivery system. It's those complementary AI algorithms that might really have some juice to it. But I don't know. I've talked too much. I don't really have a question there, but I'd love you to kind of expand on it.
Yeah, no, I think the substitute versus complement question is it's on lots of people's minds, especially radiologists and other doctors who worry about the substitution. I think that I don't. The only principled way that I can figure out to answer this is by going back to the fundamental question of what is AI good at and what is it not good at. And I think that question approximately reduces to what is in the data and what's not in the data. And because, for stuff that is where what we're trying to do is perfectly specified in the data, it's going to be very hard for humans to compete with that. Just because we don't, we just have some fundamental limits in the hardware and the software up here that, toe to toe in the data set with an algorithm doing the same thing, that's going to be very difficult for us to win. I think that the reason, in my view, it is 100% or near 100% complement, not substitute, is because there are many important things missing from the data. One of them is counterfactuals. So nothing about AI solves the fundamental problem of causal inference, which is that if you give someone a drug, you don't see what would have happened if you hadn't given them the drug. And so we don't have counterfactuals in our data set. Nothing about AI solves the counterfactual problem. So we're always going to have that uncertainty. AI also doesn't have access to things that are important but not in the data set. And so we can get AI to predict readmission very accurately and much more accurately than a human. But that AI is not going to be particularly useful for telling us, great, this person's at high risk of readmission. What can I do to reduce the risk of readmission? Are there people who are not getting access to the resources in the data that I have that should be getting access to resources and would do better if they did get access to those resources? All of these questions are questions that AI, alone cannot answer. And so I think those are the kinds of things that you're going to need humans to do, is to see around those limitations in the data and work with the AI. And importantly, act, to hold the AI accountable for those kinds of errors.
Thanks. So I think that's a thank you, not just from me, but from all the clinicians on our Zoom room. They can take a deep breath and know they're not going to be displaced anytime soon. With that, I want to invite Ting Long and Risa to come back online. They've been monitoring the Q&A, and we'll let them lead this part of our discussion. It's been great chatting with you, Ziad.
Likewise, thanks. Dan.
That's a very informative, very insightful conversation. I really enjoyed it. I do want to bring this question from Aidin Crowley. I think she was asking related to Ziad we just talked about. I think what you did was a diagnosis of the role of AI and physicians. But what about prognosis, which is how can physicians do? What's the action that should be taken? Should they prepare to incorporate AI into workflows, or should they prepare to be replaced by it? Because you recently gave a talk at Hopkins talking about AI can do certain things that no humans can possibly do. On the other hand, humans can do things that AI in the coming decades can never do, right? But what should people do? What actions should be taken in light of that?
Yeah, I mean, it's such an interesting question. I think that the at least the way I think about it is, I think clinicians have a ton of decisions that they need to make. And this is going back to one of Dan, your early points. Those decisions are usually around, here is this amazing medical technology or resource that I have available to me, whether it's a clinician's time or an expensive test or a new treatment or an old treatment or something. And so I have to make a decision about, like, do I allocate that resource or not? And I think this is why, for me, the economic way of thinking about these problems, and where AI fits in is so important, is because ultimately physicians are resource allocators in the healthcare system. That's really like the job. And what you're trying to do is say, okay, here is a patient, here is a technology, and my job is to find the optimal match of these two things. And I think that we often don't know a critical piece of information about that patient that, if we did know, would really help us allocate that thing. And so, a really trivial example is, I'm not an orthopedic surgeon. My board scores were not high enough. But if I were an orthopedic surgeon, I'd be thinking about, okay, do I replace this person's knee or not? And so I'm very focused on the knee, but that knee is inside of a patient, and that patient might have a bunch of other medical problems going on that I don't think about, that might mean that their likelihood of dying from some other thing over the next year or 5 years or whatever the life of that artificial knee is very high. So even if the knee procedure was technically feasible and could actually really help their knee pain, if this person is going to die in a year from some other thing that I can predict, that'd be really valuable to know as I think about, do I put this new knee in this patient or another patient? So that's a great prognosis question, right? It's not, I don't need to know why that person is at high risk of dying. I don't need to know a lot of other things, but that's a missing piece of information that I don't have access to, that if an algorithm could deliver to me, it would be really useful. And so I think that's my model of a lot of these prognosis and diagnosis problems, is there's some number or a probability or some other thing that would be really useful for me as I try to make decisions about resource allocation for this patient. And AI can give me that number in a way that I can't really get in any other way. And I think that's the power.
It's great. So we have so many amazing questions. So I'm going to present another one that was offered by Arushi Malhotra. So the question is, as we start to see AI tools come into medicine, how can we be mindful of rural and underserved areas that may not have immediate access to these tools? In other words, how can we prevent healthcare disparities resulting from the different access to diagnostic tools?
Yeah, I've worked on things related to this question a lot. So let me first outline the problem, which is that I think there was a little letter in JAMA a few years ago that showed that something like 70% of all AI algorithms were built on data from like 4 or 5 areas around major academic centers like Cambridge and Palo Alto and Rochester. And why is that? Well, it's because there are really smart people there, but also because those hospitals have made huge investments in data and getting the data online so that people can translate their great ideas into algorithms very easily. And having actually worked a lot with a county hospital in the Bay Area to get their electrocardiogram and electronic health record data online, I can tell you that it is not easy at all. And so I think that as a lot more people in the regulatory space have become attuned to the issue of algorithmic accountability and making sure that algorithms work well for everyone, I think a lot of people have started trying to bring those data online. And so I co-founded a company called Dandelion that you mentioned in the intro. And Dandelion tries to bring together very diverse sets of data from non-academic medical centers around the country, including the largest rural healthcare system in the US, Sanford in the Dakotas. and make those data available for people who want to build algorithms and also for people who want to validate algorithms. So we have a service where if you have, starting with electrocardiogram algorithms, but if you have an algorithm that predicts something from an electrocardiogram waveform, you can upload that algorithm to the company's protected environment where, like the IP is safe. We will give you a readout on how well that algorithm is doing overall in our data, but also broken down by these important racial groups and other protected groups that you might want to know about. And so I think that is really, really important as people start to build algorithms that want to scale outside of the health system where they were initially developed.
So now I have the honor to pick the next question. This one's from Daniel Byring. What is your opinion about using pragmatic randomized controlled trials to compare Eurocare versus Eurocare plus AI to assess impact of patient outcomes?
5 stars, highly recommend. Yeah, I think it's a great idea, and I think it really cuts down on the cost and the complexity of running these trials. And that's in fact how I'm running this trial for heart attack detection in the ER with the health system I mentioned, Providence. It's super pragmatic and low cost. It basically involves turning the algorithm on for some people and not for other people. And I think that's a great model, and all of the data, because it's linked in directly to the longitudinal health record data, you get the outcomes data directly from that. So it's very, very low cost for a randomized trial.
Okay, so the next question actually doesn't say who posted it, but it's sort of related to the emergency room work that you do. So could you describe your thoughts on an agentic AI technical approach in the emergency room to predict diagnosis that combines EMR, voice, real-time vitals, and test results, etc.?
All right, that's a complicated one. So actually, I'm going to quickly, to distract you, I'm going to answer Adam's question about radiomics, which is the company that I mentioned actually has a bunch of data that, as I mentioned, can actually accommodate these validation efforts. So Adam and anyone else who's interested in this, please contact me, and I'm happy to put you in touch with people at that company. We have a bunch of partnerships with academics that are resulting in papers, and where the company is actually making access free for those academics for academic purposes. Back to the agentic approach in the ED. I think there's a lot of excitement about capturing more and more data, voice and video and, things like that, which is great. I think that collecting richer and richer data about patients doesn't necessarily solve the problem of what you do with those data. Like, what are you predicting? So it's great to have richer and richer data that describes like the patient. But ultimately, what does AI do? It compresses all of that data down into one thing. What is that thing? Is it the probability of heart attack? Is it the probability that a bad thing will happen in general over the next few days so that I need to admit this person to the hospital or not? So it's awesome to have more and more stuff, but you still need to decide with all of that stuff, what is the thing that I'm predicting? How am I compressing all of that stuff down into a thing that is decision relevant for the emergency doctor? And I think that is still a very, very hard question to answer, even when you have all of this other data. But that data makes it much easier and more comprehensive for you to answer that question.
So I'm going to pick the question from the bottom. And so David Tang, my colleague here at Carey, asked, expanding on the issue of trust as impediment to AI adoption, to what extent might public patient prefer humans to do certain things, even if AI could be even more effective, because of perception that humans take accountability, responsibility, especially for mistakes.
Yeah, I mean, I think this is like a very reasonable preference on the part of most people, which is that, like if an AI does something wrong, who is accountable for that? Is it the company that made the AI? Is it the hospital that purchased it? Like, so there's like this diffusion of responsibility that I don't know what the legal status is or what the sort of like, how those things are going to be adjudicated. But ultimately, my view is that it's a little bit, and so I'm not saying that like there shouldn't be legal action against people who build bad algorithms, whether they're racially biased or inaccurate or whatever. But ultimately, there is a person who's applying that algorithm in their workflow and in their decision making. And that person, like should be the ultimate overseer of the algorithm. And so whatever the other faults in the system, there really needs to be a human who is actually like making sure that these things are not doing crazy crazy things in the clinical setting. And I think ultimately that person should be held accountable because they're using it as a tool to help them deliver care. My hope is that that'll help them deliver better care. But ultimately, if that's making their care worse, then I think that's their problem. And I think that they are one of the people who should be held accountable for it.
So I don't ask Dan if anything to add to this question, since trust is one of the big ideas we have at HBHI.
I'm going to pass this. So many great questions from our audience. Leave room for that.
There really are. And actually, in some of your answers, you've actually answered some of the other questions that have come up. One thing that we haven't talked so much about actually is reimbursement, how new technologies are handled by insurers. I'm going to go to this question by Ramesh Sharda, which says, it seems to me the biggest issue is how the reimbursement for any new tech is handled by insurers. For providers not get reimbursed, why would they then choose to use any new technology, including AI, and any perspectives of that? And I think many of us in this group here have worked a lot with the AI for retinopathy screening and, seeing how that has progressed from actually, getting to be reimbursed, but not, ubiquitous everywhere. It really is very challenging. So we'd all love to hear your perspectives on that.
Yeah, I love that you've been working on that retinopathy thing. I think that's a success story for this path to adoption, which is like just doing all of the work to get Medicare to have a code for it, and then to go on the road and try, and to do randomized trials that show that this improves access to underserved patients that don't have good access to a human ophthalmologist. All that stuff is just like awesome. But, as I mentioned earlier, I think the health system, for better or for worse, is very heterogeneous. And insurers are not the only people who pay for care. And in particular, I think one of the things that I foresee in the next, Dan, because you're here, I'm always thinking of like Zeke's insistence that you have a certain number of years on your prediction. So I'm going to say like 10 years. People are paying for a lot more care out of pocket. And that's a function of there are better things to pay for out of pocket. There's like more cool, convenient stuff. And also people are in high deductible plans where, it's approaching true insurance rather than like some weird wrapper around all of the financial stuff that you do in the healthcare system. And so I think those trends are going to have a huge impact on AI. And we're going to see like actually a bunch of consumer products that people are going to start to pay for. Which I think is good, largely. I think there's, of course, the potential for lots of low value, wasteful stuff, as there is in other parts of the health system where people pay out of pocket. But ultimately, if you think about incentive alignment, who better to make decisions about health than the person whose health is affected? Now, there are predictable problems with that I've studied and that, Dan, I know you've studied as well. So this is not a perfect system, but ultimately, having other options from device manufacturers to pharmaceutical companies to the consumers themselves, I think gives people who develop AI a lot more options than just having to sell to insurance companies or convince insurance companies to reimburse.
So now I get to pick this short question, but it's irresistible one from Joseph Marine. So how do we ensure that AI in practice is always under human control? What if AI goes rogue, right? What legal frameworks would be necessary?
Yeah, I wish I knew the answer to this question. I'll just maybe going back to that work that Dan, you mentioned the work from our science paper in 2019. Unfortunately, it's really hard. And it's not just hard from a legal point of view, it's hard from an operational point of view. So the system that we studied, it was put in place by the Pop Health Management Group at a large health system, just like it was in many other health systems. And that system generated for each primary care doctor a list of their patients that they knew and a recommendation about whether they should get access to high-risk care management or not. And what we found was that unfortunately, the primary care doctors basically just accepted all of the algorithm's recommendations without modifying them at all, and specifically without catching the very large racial bias that the algorithm had built in to its recommendations about who should get access to care or not. And so, it's not just a legal problem, it's that even when you build a human into the loop, because that human is really busy. Like, I don't think this is like, a primary care, primary care doctors just keep getting stuff added to their jobs. And now it's like, all right, now I got to review like for all of my patients every quarter who need so that person's not going to go through and, line by line figure out like who needs X and who doesn't. They're just gonna be like, okay, now I got to do all this other stuff and I have to answer 1,200 messages on my stupid inbox. And so I think there are a couple of things. One is that I think as people realize that having a pro forma human in the loop is not enough, they'll start to resource this appropriately. It's the optimistic worldview. I think the pessimistic worldview is that there's going to be more and more state attorneys general and other regulators looking into cases of algorithms behaving badly and holding a bunch of people accountable for it, not just the people who make them, but the people who buy them and implement them and things like that. And I think that will probably generate enough interest from all of the people in that value chain to try to design the system in a more responsible way.
Amazing. So I think we'll start to wrap up. I know there are still more questions, but we've answered a lot of them, and really it was a great discussion. I'm going to allow Ting Long to introduce our speaker for next month, but we really want to give a huge thank you to Dr. Polsky and Dr. Obermeyer for this really enlightening discussion. We've covered so many topics in under an hour. It's really incredible.
Thank you so much. This is so much fun.
Yeah,
Thanks
thanks
a lot.
both of you. We still have quite a lot of questions unaddressed, but we will make sure to pass on them to both panelists and also please still engage it. And so as I said at the very beginning, this is part of HBHI, Workgroup on AI and Healthcare. We meet monthly. Our next seminar on February 21st will feature Dr. Mihaly Vanderskar of University of Cambridge. We hope you can join us.
And if you want to get on the listserv and you're not part of the AI and Healthcare work group, you can send a note to HBHI or Miana, or and we'll add you to the listserv.
Thank you, everyone.
Thank you, everybody.